Welcome back to the Dr. Greg Jones Optimization Academy podcast. And today we're diving into the world of peptides and functional medicine to uncover powerful tools for healing and pain relief. Joining me today are two remarkable experts, Dr. Garrett Morris, a board certified internal medicine physician with advanced training in obesity and cellular medicine, and Dr. Asare Christian, an integrative pain management specialist whose work focuses on performance enhancement and health span optimization. In this episode today, we're going to discuss their journeys from conventional to regenerative medicine, how they approach both acute and chronic pain, and explore cutting edge treatments like peptides and regenerative therapies. We'll also dive into their top recommendations for diet, lifestyle, and supplements that can help manage and relieve pain. So, everyone, welcome Dr. Morris and Dr. Christian to the show. All right, man. I am so excited to have you guys on the show. And first we want to know a little bit more about you guys. I kind of did your intro here and a little background. I've met these guys that I feel like every time I go to a peptide conference or a longevity conference, it's like we run into each other like, hey, and one, because we see each other a lot, and B, let's just keep it real. There aren't very many black men.
That's true.
So I see you. It's like, hey, we're just there's an excitement. There's a pride. And you guys have been there, man. I'm excited for the journey here. So, but I know that you both come from a more traditional medical background, right? And I'm really fascinated. As many times that we've seen each other at conferences, we're usually just in pass and go. We never really get to sit down and just say, hey, how'd you get here, right? And so I definitely want to talk to you guys about that. So, man, Dr. Morris, man, so let's start with you, man. How did you transition from internal medicine into this functional cellular medicine regen space?
So it all began honestly with like watching patients really not get as well as they should. And for a little bit of background, I know you did my bio. I'm from the Caribbean, so we see medicine a little bit differently. So I grew up with a lot of like herbal remedies, a lot of more of the, I would say, Eastern type of medicine, the way they do things. So I grew up with that. So moving to the US for me was a huge change, where it was like, oh, you're going to take a drug for that? Or when I know, well, we could actually use a little bit of some herbal medicine here and get the same bang for buck without some of the side effects. And then diving into functional medicine happened for me around about 8, 9 years ago, and it happened through my wife. Actually, she's a physician, and she this decided to go into it because of like health issues she was having. And I watched, and honestly, I'll tell you straight up, like other regular physicians, and I know Asari Dr. Christian can attest to this. We in the beginning tend to see functional medicine as almost kind of way too much out there, kind of wackadoo medicine, But after I went to my first A4M conference, like I said, about 8, 9 years ago, and I realized how much science was in the conference and what they were discussing and the leaders who were in that space and what they were doing. I was like, oh my God, this is deep. I mean, a lot more than what we get in the traditional medicine space as a primary care physician myself, a lot more than we got, So it kind of piqued my interest. So I dove deep into it. So she actually went ahead and went the full Monty on it and got certified. So I just kind of followed the principles that she was doing in her lectures. But what piqued my interest was peptides. So when it first came on the scene through obviously A4M, and I did the lectures through them, and I was wondering, okay, so you tell me this small molecule, a couple, peptide subunits put together, can do all these things and make people better and achieve change on a cellular level. So that kind of opened up my eyes to the fact that there's a whole other side of medicine that I think people need access to. And we being the ones in the space who are around others who are doing it and who are doing the work to figure out what we can do to help patients, I think it just kind of, once again, took me deeper down the rabbit hole, but in a good way where I was able to kind of build protocols for my patients and kind of really see people begin to thrive and not just survive in my medical practice. So we've kind of moved our practice, at least over this last couple of years, we're moving more towards a longevity focus, and that comes from the fact that people are asking for it. And patients now, I think the consumer now is a lot more educated on not just taking a pill to stay alive, but thriving and being able to beat the odds, whether the family history is wrought full of, health issues. Doc, how can I avoid that? These are kind of questions I'm having now with my clients. And it's amazing because these are the ones I want to have. Not the typical just give me the cholesterol pill, let me go. It's what else can I do? So for
Right.
me, it's been a game changer in my practice, just kind of diving into it. And I love the fact that there's always something new on the horizon. There's always a new way of looking at a puzzle meaning a patient, and figuring out, okay, maybe we can try this. And that's the key to cellular medicine, as you know, Dr. Jones and Dr. Christian. That's the key to it. Once you understand the chemical makeup and the different structures of the molecules and where they fit and the different cascades, and if you realize and you understand that physiology really well, as you know we all do through our training with cellular medicine and functional medicine, you can begin to kind of put things together in your head that just won't make sense to others, but to you, because you understand the science, game changer for your patients. So
Yeah.
that was my dive into functional medicine.
No, that's
I'm
great.
never
And I
going
think
back.
no, and I don't blame you, man.
No.
We're glad to have you. Glad to have you here, man. So, man, Dr. Christian, sorry, man. How did you? Because if I, from we talked about your bio a little bit, before we
Yes.
started. So your background is more in the physical medicine rehab, kind of the pain relief kind of world. And how'd you, kind of shift that path towards this integrative and peptide therapies for pain relief and optimization in your practice?
Yeah. So, Dr. Jones, Dr. Morris, first, I want to say thank you so much for having me here because, like you said, I met you guys through this peptide conference, through Dr. William C's conference. And before I talk about a little bit about myself, I really want to tell you how much I really appreciate seeing you guys there and all the support you've given me because I'm in this space for the last 2-3 years ago. And then the first time I came to the conference, I was standing around and you guys were talking. And it was like a foreign language. And we're going to talk about peptides. And I was like,
Yeah.
what the hell are they talking about? I went to medical school too, but how come I've never heard of these things? So really an honor to be here and to kind of always see you guys is always inspiring and is supportive. So my background, like you said, is in pain medicine and previously working in a rehab hospital. In fact, I didn't want to do pain. I kind of, during my residency, after finishing residency, I have 5 in my class. They all went to do pain fellowship. And I was like, you know what? Pain is not clear. It's very subjective. I want to do, public health. And I went to get a public health degree and do it in fellowship. And when I was doing public health, I became aware of the biggest public health in America was actually pain. There's more people in pain than diabetes, heart disease, and cancer combined. And that costs a lot of money. And basically, public health is anything that costs a lot of money and affects a lot of people and is preventable. So I didn't want to do pain. I started working in a rehab hospital, did that for 8 years, taking care of pain patients with neurogenic backgrounds, so spinal cord injury, TBI, stroke, all of those people, complex pain conditions. And through that experience, and then seeing regular people with musculoskeletal issues, neck, back issues, tendon, all those things that we see. I kind of knew that what I was doing wasn't enough, like blocking pain signals. I can do injections, I can do medications, but people kept coming back. And those that actually did well were the people that were healthy, which I already intuitively know. So the inception for me switching from where I was to where I am now 3 years ago was to try to figure out a way to make people healthy. Because I recognize that when people were healthy, then pain gets better. The outcomes of all the interventions we did got better. The surgery outcomes were better. The medications outcomes were better. The supplement, energy medicine, everything else gets better when people were healthy. But the sad thing is when I started this practice, even though that was the inception was to use health as a way to solve pain. Somebody who's been, in medicine for 8 years, I did not know how to solve health. As Dr. Morris was talking about, like all these cellular pathways that we learn in medical school. Once you become a resident, once you become an attending, you're solving sickness. And basically what we're doing is blocking pain signals and patching up things, right? In the hospitals and in our residencies, which I understand. In the hospitals, that's not where they're talking about nutrition. So really in the outpatient setting, I lack that knowledge of how do I solve health. So through that was the inception. And I think if you have an idea and if you want to find solutions, they kind of come to you. Somehow I got connected into this space of peptides. So I did a peptide conference with Jim Lavelle. That was my first exposure. And then before then, I've actually looked up Dr. Greg. I saw you on a peptide, and I was like, "Who is this guy? And what is all these things that they're doing?" And I was like, "This is really, interesting." So I did that, and then while I was there, I also came across William Seed, and then from there, that's how I got into this space. And since then, really trying to figure out how do I solve health, working on the microbiome, working on the HPA axis, and doing all of those things. And I've also come to the place, just as Dr. Morris is saying, is this idea of longevity. And for me, it's all about public health. And one of the biggest risk factor for any disease state is aging, even pain, osteoarthritis of the knee, back pain, all of that happens in aging. So if I really want to solve the problem and get to root cause, I also have to understand, figure out how to solve aging or how to slow down aging. So super excited to be here. I know it's a long way to get to where to answer the question, but super excited to be here with you guys, and so honored to be learning from you and having this discussion. Yeah.
No, and I really do appreciate you guys making time. And I think we were leaving Miami, and we rode back in the cab together, me and Dr. Christian, and we're kind of talking about how'd you get into this. And I think you hit it right on the head. And I was like, hey, when I got out of school, I was all about regenerative injections, man. I just wanted to, man, I was just ready, man, have needle will travel. You got pain, I'm injecting you. Never met a joint I didn't want to inject. And one thing that I learned, it was like, hey, I'd have these major two subsets of patients, and you have someone who hurt themselves, had an injury, and it's like, all right, well, come on in, we do your workup, do your orthopedic exams. Hey, I'm going to do an injection, and you can inject this person with PRP or prolotherapy or a regenerative product, and it's like that healing process would be slower because they were inflamed and their diet was horrible and they were obese, and it's just like, I got to get you out of pain, but there's other things to deal with first. Yeah. And then I would realize you'd have people who were active, had that CrossFit injury, you treat them, do their injections, and boom, you never see them again. Not because they hate you, it's because I did my injection, I'm 100% good. I'm good, no reason to come back, right? And so that's where that mindset shift came in, where it's like, wait a minute, let's get the foundation, because a lot of people sometimes they don't need that. They need to kind of get their foundation set. And that's huge. Now, one of the things in the intro that I was talking about is that we're all going to deal with pain. We're all going to, at some point in our life, you're going to be in pain. You're going to get injured. It's just what it is. I mean, eventually something's going to happen. You can't live in bubble wrap the whole time, but there's a difference between, hey, this just happened versus which is an acute pain versus a chronic pain, which has been there forever. And we all know those people. It's like, man, my back's been hurting. How long? 20 years, 10 years, 15 years. You're like, oh, wow, how'd this happen? So when it comes down to it, Dr. Morris, when that person comes in, how are you differentiating between that acute pain and chronic pain?
Well, I mean, in my practice, it's pretty much timeline. So we look at what was the event that triggered this episode or this current pain syndrome or cascade? And we always ask, what have you been doing since it happened? And you'd be surprised, and you wouldn't be surprised, but I'm sure you've met patients. They will suffer for a while before they actually come in, depending on where the pain is. Mm-hmm. So you'd have patients and they will literally just begin to adjust lifestyle. So most people tend to think, and this is what I've seen in my practice is, I'll just ignore it and eventually it'll get better. No, but pain's a signal. Pain is something that's going on. So I like to tell my patients who are dealing with chronic pain, especially when it begins and we're in the early stages of it before it goes chronic, I tell them, listen, you got a forest and one tree's on fire right now. So you have a choice to make. Either we can do the good work and put that tree out now, or we can limp along and let that one tree turn into 1,000 acres. And then trying to put that fire out with medical therapeutics is going to be a difficult task, is going to take longer. So we just have the conversation, do the full medical history and examination. What caused this? What have you been doing? And kind of realign. And to Dr. Christian's point, it's all about health. A lot of people don't realize that how their lifestyle really significantly impacts their pain journey. Yep. It's amazing. I mean, obviously for us, because we're in the science space, it's a no-brainer. But some things, like let's look at obesity. Okay, you have someone who has moderate to severe DJD in both knees or in one knee, and they're carrying the extra 15, 20 pounds of weight that we know. Here's the thing with, as you know, with obesity, right? The fat cells, that's also a factory for inflammation. So you not only have that factory creating the inflammation, you also have the weight because of gravity on those joints. And they come in, and Dr. Christian, I know you've seen them, right? They come in for their back injection or the gen block in the knee, and you're looking at them going, yeah, you're 50 pounds overweight. I mean, I can do the procedure, and you'll get relief for what? 2 weeks? Maybe 3 months at the best, but you'll be back. That's okay. And no one wants to address the real issue. Smoking, another big one. Alcohol, another big one. I tell them, listen, if we are going to beat this thing, everything has to fall into alignment. And sadly, a lot of people are not willing to make that mindset shift and realize that. So if I stop smoking a pack of cigarettes a day and doing the 6 pack of beer, my pain can get better. I'm like, yeah, your neuropathy will get better. Let's start there. So that's pretty much it. Just do the physical, figure out what's the nidus of the issue, and then kind of tackle it head on. So and that's what we do.
Now you hit like a great segue there because you mentioned the tree on fire and turning into a forest. And so to me, the first thing I think is inflammation. And you mentioned the fat cells are this factory for inflammation, right? So now, Dr. Christian, I know you're coming, originally you came from more of that traditional medical world where it's like, hey, you're in pain, you're inflamed. I got something for you. What's up, steroid shot? What up? It's like I got something. I got
the roids. I got the roids for you.
I got something for you again. So, and again, I get it.
Yeah.
In many ways, it's like, hey, you're in pain. We got to get you out of pain quick. This is the thing, right? But again, that comes down to that question of like, hey, you know what? This is that Band-Aid, but eventually it's not fixing the problem. So that being said, when you look at acute and chronic pain and the role of inflammation, how are you processing that now that you kind of came from your original home of, the steroid, not saying like you were just out there passing on steroid injections, but knowing that, and then now you see there's an entire different world of reducing pain and inflammation. Like, how does that change? And to ask that question a little more directly is like, where do you see, how's your mindset shifted in how to deal with inflammation and pain and using those tools?
Yeah, so that's a great question. And I think you hit a lot of things on the nail with how conventionally or previously, basically what we do is block pain signals. And in fact, if you look at all the medicines we have in pain management, gabapentinoids, Lyrica, all of these things that we use, they are all sodium channel blockade. They basically blocking the pain signal. So even stepping back a little bit, I think one of the things that we actually have to kind of define is what is pain? Because one of the things I recognize in this transition is patients actually don't understand what pain is. And pain is just a very subjective experience. So if the person who's experiencing doesn't know pain, how are they going to really solve it? So pain, by definition, is a sensory, an unpleasant sensory and emotional experience that may be related to a tissue damage or no tissue damage. So that's the idea. So there's an emotional component to the pain and the sensory component. So that's something that I think sometimes we kind of forget. Of course, the sensory component is the physiology, all of this inflammation that's going on. There is also the emotional component. There's always emotion related to pain signal. And the whole purpose of having emotion attached to pain is that emotion crystallized memory. And the whole purpose of pain is a protective mechanism. As like Dr. Morris said, it's like the signal that something is wrong. There's one thing that if we don't take care of it, so what is it? So I try to kind of start from really educating people and then getting back to acute pain, which is pain that happens less than 3 months. Chronic pain is something. But the whole important concept to recognize is that when people have pain initially, if it's a simple trauma, right, we understand there's a cascade of inflammation that's taking place, cascade of cells that becomes activated, all of that goes to the spinal cord, it goes to the brain. But then when the pain hangs around for too long, that whole process becomes dysregulated. So in trying to attack acute pain, which I think I like. When people come in and they've just strained their back, most of the time it's just a muscle thing. Let's work on sleep. Let's work on stress response. Let's dial in nutrition. All of those things influence your ability to heal and control inflammation. When the pain is chronic, we have to do all of that and also talk about how we get people to actually address the neuroaffective component of the pain. So coming to this space now, I just don't go with let's block the injections, let's block all of these things, but really understanding the inflammation because first of all, the inflammation is there to heal. So when we give you NSAIDs, we are blocking the COX pathway. There's this two pathway, right? Inflammation is happening where we have COX pathway that's going to create prostaglandin. That's going to cause pain. And you also have LAX pathway, which is going to create the pro-resolving mediators that's actually going to help you heal. So I've come to the place now where I just don't block the whole signal because if I block it, you don't heal. And in fact, that's what a lot of people have been caught up in. They keep taking Tylenol or they keep taking, ibuprofen or whatever NSAIDs it is, and it's not solving the problem. So now I understand those things, and I also understand other things that influence that whole cascade. Hormones plays a role in that. The microbiome plays a role in that. Aging plays a role in all of that. So I'm at a place where now I look at all of those things and try to figure out where do we start. And to the very point, if a patient comes in front of you and if you don't solve their problem right away, then they're not coming back. Sometimes you may lose them. So definitely there's a place for pharmacological agents and blockades and all of those things, but going beyond to educate people to say, okay, now we got to change some habits. If you're not sleeping, pain is not going to get better. If you're smoking, that's not going to get better. So a lot of education before medication. So that's what we do now. A lot of education before medication. Yep.
I like that one. Education before medication. But
I'm gonna steal that one. I'm gonna steal that one.
Sorry, it's stolen. It's just like, but it's kind of like gonna realize like look, man. But but that's important to have that talk. But as our patients come in and they're in pain. Yes. I like that. Educate me, but you got to get me out of this pain. So I think it's just so it's like why you're making those decisions. And I think you hit a very key point, and you both really did, is that look, inflammation is nothing to be afraid of or feel like, you can never have inflammation, because inflammation is how your body heals. It's how we fight infection. It's how we do so many processes with the immune system. And that acute inflammation, when you first sprain your ankle, like that's your body sending those proteins in there to get you healed and all that. It's just when it doesn't turn off. And you mentioned that dysregulation, yes. And that's the challenge on why, and there's so many reasons why, like why didn't your immune system turn off? Why are you still producing inflammatory proteins? And we're going to talk about some of these things in a little bit. It's like, okay, are you feeding the fire? Like, are you eating inflammatory foods? Are you not sleeping? Are you under stress? All these things come into play. And it's just when that inflammation is correct, when it doesn't turn off, it becomes that chronic inflammation, that metabolic inflammation, that metaflammaging or inflammaging. There's so many words for it, but essentially it's that low-grade smoldering inflammation. It's that low-key pain inflammation that doesn't go away. And there's a lot of things that contribute to that, right? And I think that's so major in trying to get people better long-term. It's like get that inflammation off so your body can get that healing process going. Now, kind of getting now.
I want to add something very quickly. So I think one of the other concept too in pain that we tend to forget is like there's three type of inflammation that goes on in pain. So you have the inflammation, which is a regular inflammatory cascade, nociceptive, and then you also have neurogenic inflammation, which is the nerves. When you have an injury, the nerves actually creates inflammation. That's actually what pushes chronic pain in the periphery. And then you have neuroinflammation that's happening in the spinal cord and in the brain. That's what keeps chronic pain in place. So inflammation has a place. We have to think about neurogenic inflammation. We also have to think about neuroinflammation as a whole system that are involved in the whole pain cascade.
No, super important, because that way it's never just treating one part of the pathway. And then I know we'll talk about regen injections later on. There's a lot of cases where if I'm doing your joint injection, I may do some perineural as well, and I try to reduce that neuroinflammation. So we'll get into all of that stuff later. A little sneak peek on some of the therapies though. So now, so let's say that patient comes in, doc, I've been in pain. Like this hurts, been hurting for a while. It's like it's still there. It's bothering me, all that. And then it's just like, okay, you do your intake, you do your workup, you do the PEs. So Dr. Morris, when do you think, all right, let me do some imaging. Let me do an MRI or an X-ray or a CT scan or, the imaging of choice for that particular body part. What's your kind of flag for that?
So it all depends, like you said, on the presentation. So if there is typically a traumatic event, like I fell off a ladder 2, 3, 4 weeks ago, right? And I fell onto my elbow and now I can barely move it. So trauma, that's a big one for me, where I'm like, after examining, depending on how range of motion's hampered or the overall look of the joint or the area that's damaged, if it looks like, okay, this is a little bit longer than it should be and it hurts a little bit more than it should for this particular type of trauma, maybe we should at least get a basic x-ray just to make sure that we don't have anything broken. And also it depends on the patient's age. So anyone who is in that dangerous age, meaning above the age of 55, 60, where especially women who are in that post-perimenopause, post-menopausal state where, they begin to have osteoporotic issues, then you want to be careful and say, okay, good, let's just do that. And also if they have chronic issues like uncontrolled diabetes, uncontrolled cholesterol, cancer diagnosis. So it all depends on what they're coming in with. Then we say, okay, good. And the level of injury that they had. Now, my go-to for MRIs or even CT scans, because some people, can't have MRIs because of pacemakers they may have or certain implants. So those imaging studies, I like if I'm trying to rule out a neuritis or some kind of neurological claudication type situation going on. Meaning, if they come in and, for example, doc, like I fell off the ladder onto my outstretched hand 4 or 5 weeks ago, and over the last couple weeks, I'm losing function in my bicep. I'm feeling as if it's getting weaker, and when I examine them, it's noticeably weaker. And I'm like, oh wow, yeah. Or for some of those patients who kind of coast until it really is really bad, then they come to see you, which we all have some of those. You can literally look and you can see the muscle mass on one side begin to shrink compared to the other side. And you ask the question, what's going on here? Oh yeah, I fell a couple months ago. And I just have, it's been getting weaker, but I've been just managing it until I could see you. And then you're like, whoa, okay, this is bad. So yeah, when there's nerve impingement, that's when I'm like, okay, we can't afford to waste time. I need to know what's going on. And especially when they're talking about things like numbness, tingling, and of course, worst case scenario, weakness or loss of muscle function. Then that's when I default to the MRI modality.
Okay. So, Dr. Christian, so is that similar to your thought process on imaging, ordering, and?
Yeah, absolutely. Very similar. And everything Dr. Morris said is how I look at it also, who it is, what's been going on. And, but, I see a lot of spine issues. And so specifically, spine is one of those that patient comes in and they're going to be asking for imaging, right? My back hurts. I did something, So really ruling out neurological issues. Is there any weakness? Is there any numbness and tingling? Ruling out any bowel bladder issues. You want to rule out quad equina. If they are old and it's not, context specific, meaning, they're older in the 60s, they woke up with this back pain. You want to rule out other type of, issues. Pyelonephritis, is it a cancer? All of those things. But one of the things that I try to stress for patients, because patients have had all these MRIs and imaging when they come to me, they've seen multiple doctors. The issue is that your MRIs doesn't tell us where your pain is coming from. Your imaging just shows us structure. It helps us to exclude because there's multiple things in the back that can hurt. And pain is not just what we see in your picture. So people come in and I ask them, oh, why do you have pain? It's my L4 herniation. Even though L4 herniation has been healed, they're still in pain. So really the imaging, I think, for us as clinicians is that it helps us to exclude things, but patients tends to focus on it so much like, oh, find it, because they want somebody to find something they can inject or do surgery, because people do all of those things and they're still in pain. Why? Because they're not aware of what's keeping them in pain, which is their habit. So very similar to Dr. Morris, we want to rule out neurological issues, but we also want to stress to patient that their MRI doesn't tell us where your pain is coming from, because there's people out there who don't have any back pain and you do MRIs of their back and they have all these herniations. There's people around the world who have all these herniations at hills. In America, we use that. And the more imaging we actually do, we end up doing more surgeries. So people get this all MRIs, and then there's something that, oh, we think this is what is going on. Not asking about the fact that they just lost somebody in their family. That's going to influence their pain. So I've seen patients done all these surgeries and they come in, it's actually their hip. So there's a place for imaging, but I think we tend to do a whole lot more in America. And it's also patients have to clear and understand that the imaging doesn't tell us where your pain is coming from. But obviously we want to rule out any neurological or potential injuries. Yeah.
To your point, Dr. Christian, beautifully said. I actually had a patient today who we did an MRI of her knee, 6 months of pain, X-ray didn't show much. And, it's kind of one of those, it hurts. And there's a pinpoint area, and did the MRI, and a little bit of chondromalacia behind the actual patella. So, and a little bit of loss of the actual synovium in there. So I mean, there is some disease in there. And get this, there's a very small Baker cyst in the back of the knee. So I send the message to the patient, hey, you know what? Imaging done, MRI, I reviewed it. Maybe some mild arthritis in there, all ligaments intact, not much else to cause the pain. Let's continue with physical therapy and see how they go. So apparently the message I got back from the patient is, what about my Baker cyst? I was like, because the patients, they get a copy. And I was like, well, I didn't mention it because it's inconsequential. It's so small that the amount of pain you're having and the location of the Baker cyst is not anatomically what's causing the issue we're having. But it just goes to show, with some of the imaging, it's a double-edged sword, So it's something that we always kind of wrestle with, because they're gonna find some stuff in there, and then now you're gonna be like, okay, how do I let the patient know that this, although we see it, it does not mean it's causing your pain.
And that's great. And for me, just because again, Dr. Christian, you came from that pain relief world, and so imaging with us is like, yes, you want that information, but kind of how I was trained. I've had some really great doctors in the ortho world train me, like, hey, start with this. Hey, do you think that imaging is going to change how you treat this patient?
Treatment. Yeah.
If you're like, wait a minute, like, let me get this first because I may end up injecting something different, or maybe we don't even need an injection. I may look at that. The other thing for me is kind of like, this is the Dr. Jones thing, just from my clinical experience with this, is like, okay, if that pain, like sharp pain is like one of my red flags, right? It's one thing to have dull, annoying, but if it's like sharp, like, oh shit, like that you mentioned, Dr. Morris, that warning signal from the body, if that pain is sharp, like your body's talking to you, like, look, whatever you're doing, you need to stop and get it figured out. For me, the other is weakness. Like if I do, like if I do an O'Brien's, ortho test to test your labrum, and I press down and you're like, you can't even hold your elbow up. We're need to, and for me, it comes down, the reason I'm doing that is because that super sharp pain, you lost function, you've lost strength, is I need to make sure that ligament is still attached. I need to make sure that tendon is still there, because if it's fully, we'll get into regen injections. If you've got something there, you got to give a brother something to work with, right? If you got some attachment there, I got you. But if you're literally, full tear, it's like, man, I can pour peptides, all the peptides in the world in there, but it's just not there. There's no bridge to cross, right? And so in those cases, imaging can help you, because it's like, all right, man, you know what? I think we need to take a look at this, because based on what I'm seeing, what you're describing in the PE, this may be more severe than what we're letting on. And instability, right? If you're like, my knee gives out, like, what do you mean gives out? It's like, I fall down.
gives out what?
You're like, wait a minute, like this thing is shut down for the summer, man. So I want to kind of, you guys kind of hit this earlier too, and I want to circle back to it, is getting that foundation set when it comes to helping your patients deal with chronic pain and even acute pain. So when that person comes in and it's like, it's inflammation, you can see it, it's in the labs, the whole shebang. So starting with Dr. Morris, like, what are some of the best recommendations you look at or discuss with your patients when it comes to diet and supplementation?
Oh, well, I go heavy on lifestyle. I mean, I ask about sleep. I ask about the smoking, or any kind of vice, alcohol, and just yesterday I saw a guy, and I saw him for weight loss, right? But he has chronic pain. And and literally he cut back. So he's doing like about 2 to 4 beers a day, and he still smokes pipes, like two. I don't know how they measure it, but he basically like 2 to 3 times a day he does the pipe smoking. So I told him, listen, with regards to the weight loss, first of all, that's a no-no. We're gonna have to stop that. But with your chronic pain that you're in, although it's not why you're here to see me, you need to quit those things, because all you're doing is keeping that inflammation around. That's that squatter in your house that you can't get rid of. So you need to get rid of those 2 vices over time, and you will see your pain, obviously over time, not like a tomorrow thing, but over time begin to reduce with everything you're doing to feel better. And his eyes open, and he's like, wait, what? I'm like, yeah, if you put those away, give your body time to heal. Without that, you're going to feel better. Another big one for me as a primary care doc is diabetes. I mean, the stats on insulin resistance in this country is ridiculous. We're looking at over 44 million people eventually at some point in time. And there are a lot of people who don't know that they have pre-diabetes or insulin resistance, and they're walking around consuming all these processed foods, living a stressful lifestyle. So that's a big one. And the patients who I know who do not do well on their chronic pain journeys are the ones who have very poorly controlled diabetes. And I've seen them, and it's kind of one of those where people don't make that connection between if my blood sugar stay under 120, I'm going to have less pain overall. I'm like, yes, but I still want to have my donut at bedtime. I still want to eat my ice cream. I still want to eat my fast food. I'm like, well, we need to find something, and this is your choice as an adult. I mean, I tell patients, guys, and this is something that I think hits home when I tell them, in this country or in your lifetime, you will pay for healthcare with 2 options. Either one, you pay for it by choice, or pay for it by force. So that's 2, 1 or 2. Force is when you ignore all the advice from docs like us, you live your life, And then you have a cataclysmic health issue where now you have no choice but to spend money on your health out of your control, meaning hospital bills, medications, surgeries, treatments, IVs, all that stuff, which you don't really want to do. That's the force. By choice is going early, getting evaluated, talking to people like us, having that relationship and letting us tell them, hey, this is the path you're heading down. Here's the things you can do. In my head, oh, that's an investment. It's not, you're not paying, you're investing in your future. So I tell patients, you have two options. You can either pay for your health by choice or pay for it by force. What's it going to be? And when they hear that and I explain, they're like, oh, okay. I'm like, yeah, because this is the reality, you know?
No, it's true. It's true. And so like by choice or by
Or by
force.
force.
By
Yeah,
force. Like you don't have a choice. You are
exactly.
you're there. You're there,
I mean, Dr. Jones, if someone has a heart attack right now, where are they going to go? Straight to the hospital. There's no going home and chilling. You go straight to the hospital. You get discharged on like 5, 6 different meds. You now have to follow up with the cardiologist. You now have to do cardiac rehab. You now have to do all those things. When a week ago you were smoking your cigarettes like nobody's business and you didn't have any issues. Well, you thought you didn't. But you see, but this is the by force because people ignore the warning signs. They ignore the Surgeon General marking on the box of the cigarette that says, "Don't smoke this crap; it's going to kill you," and or they ignore the fact that more and more people are getting more and more obese and sicker with the foods that we produce. It's ridiculous.
No, it is. It is. And that's why I'm glad, you guys are in this world of making these changes and helping people make the changes. So, Dr. Christian, so what are your top foundational things when it comes to helping your patients with chronic pain?
Yeah, so going off everything that Dr. Morris said, really the lifestyle part of it. So when patients comes in with pain condition, if it's that's an example, they sprain a muscle, they tore a ligament, something like that. Really providing some education for them to understand that this has happened for a reason, and pain is there to teach them something. So we got to pay attention, and we have to focus on the factors that are actually going to get rid of the pain and not transition from an acute to chronic pain. So as a pain doctor, one of the things I'm very interested in is how do we prevent acute pain from becoming chronic pain? Because once it becomes chronic pain, there's all of this dysregulation that has taken place. And now everything that body actually supposed to do to help you heal has actually changed around. So when people come in with acute injuries, what I do is focus on really trying to modulate that inflammation or whatever that injury is, modulate immune activity, and also provide the support for healing. So a couple of things that I use outside of the nutritional sleep. I talk about sleep. You make collagen when you're sleeping, so let's get you to get good sleep. Let's not drink alcohol. Let's do all of these things. That helps. And then foundationally, I like to use specialized pro-resolving mediators as a way to kind of help. That will address inflammation, neurogenic inflammation, and neuroinflammation. I also will bring in some collagen, some vitamin C. Those are all immune modulatory to kind of really help people to heal. And then I focus on, okay, let's get you to eat good protein. If it's young people, to kind of try to support all of that cascade to heal, and talk about how do we strengthen. Because the other thing that also happens when people have acute pain is there is always going to be some biomechanical deficit. Let's get things to heal, and then let's figure out how to strengthen, because muscles are going to be inhibited because of pain, and then people compensate. There's all of this compensation that goes on when people have pain, and then they have other issues. They came in with knee pain, doesn't get better, they're limping, the next time they have hip pain. So really kind of providing overall education, lifestyle, and then dialing in those things, and then blocking the pain signal, because sometimes people need to feel better. Otherwise, they can't do the therapy, they can't do the other things. So, even if there's a place for NSAIDs, we are looking at some stuff for the microbiome to support that, and then short courses or using things that are actually safer, depending on the person. Obviously, if it's older person, they have other cardiovascular risks or cerebrovascular risks, you can use it. So patient specific, but basically modulate inflammation and then getting them to do the right habits that gets them to heal.
Yeah, and that, I know I didn't mention, but I know you touched on a couple of supplements, which is good. So tons of herbal remedies that are out there. Yep. I mean, I know, Greg, I know you know a bunch of them, obviously. I mean, Dr. Jones, you have this turmeric. I love turmeric for my patients. I also use peptides, as I know we're going to dive into later on, I'm sure. So there's some really good oral peptides that you can use. to help, modulate once again the inflammatory response. I mean, the big fight is inflammation. We all know that. That's where we need to tackle. Once you can get inflammation under control, pain gets a lot better to manage, so to speak.
Yeah. And so there's so many supplements, man. We can do a whole podcast on all the different supplements for pain relief. And you hit a big one with turmeric and curcuma. But some of the things, like when I look at the lab work and I look at the patient case, I'm always looking at, okay, what are some of the foundational things that are almost like across the board? If this is off, you're probably going to be in more pain and inflammation. And so we've kind of been dancing around them. But for me, when I'm looking at this person, hey, I got chronic pain, I got that joint pain, I'm aching, I can't recover from my workouts, my muscles are sore. When I look at their lab work, I'm going straight to their CRP and sedimentation rate. I'm going straight to their vitamin D. I'm going straight to their hormones, especially their testosterone and their DHEA sulfate. I'm actually looking at their thyroid. I'm looking at all these different things that can tell me. It's like, wait a minute, if your hormones are out of whack, and even in female patients, if you're postmenopausal and you don't have estrogen, you're probably going to be in more joint pain. So we're looking at all these different factors, because there's a lot of people where it's just like, how many people have you seen where it's like, hey, my knee hurts. Okay, I got a little shoulder pain. I got these different aches and pains. And I'm like, okay, all right, bro, you got a 225 testosterone. So let's start with that. And you get their testosterone to a more optimal range, and you see them in 3 months, and then it's like, hey, how's that shoulder? Like, what shoulder? Oh, yeah, I forgot about that. You're like, oh, yeah, or that knee, because again, it helps with reducing inflammation. So I think, again, we're looking at the whole picture, because again, sometimes it's not about just jump to a medication, or even like, I love supplements. I love supplements, but sometimes it's like, wait a minute, what's off foundationally? Why isn't that pain signal turning off? And let's start with that. And then you have your autoimmune conditions, right? And that's a whole other, ball of wax right there. How you notice that some people with more autoimmune conditions tend to have more pain because their immune system is so dysregulated. You're just putting out cytokines, right? And so all these things come into play. But great segue, Dr. Morris, because I was like, you know what? I know people are like, I thought there was a talk on peptides and healing. It's 40 minutes in. They ain't said a damn peptide yet. That being said, the fun part of it here. So as we know, last September, there were some changes in the peptides that were available that got put on a list called Category 2, where the compound pharmacies could not make them. Since then, and this year and some change, some of the peptides, there are alternatives that have came out. Some of the peptides have come back. So we're in a kind of, by the time this podcast is released, who knows what we're going to have available. But I want to start with this one, because the first peptide everyone thought about when you're in pain is BPC 157. The Wolverine peptide, the healing peptide. This peptide, you can put it in your bath water, put it in your drinking water. BPC is great. And it did
everywhere.
It helped so many patients, right? But now BPC is no longer available in the injectable form. What has been your top sort of alternative or substitute for the BPC 157 when it comes to healing?
So with regards to peptides, so BPC in the injectable form, yes, game changer. I used to use that for trigger point injections for patients. So yes, but the nutraceutical form of BPC is still available, which is good, which is the over-the-counter oral form. And what we do know is that BPC in the oral form and BPC in the actual injectable form, the bioavailability are pretty much very close. So going oral is what I have to transition patients to. And we are still seeing really good improvements with regards to healing, with regards to collagen building. I mean, I've actually put it in my post-surgical protocol. So all my patients, when they're going to, I say, if you're going to have surgery, let me know. Because what we do is we normally prep their bodies for the surgery. So we put them on an actual protocol where we have BPC in the beginning for at least a week or 2 weeks before the surgery. Then once they get the surgery, we continue BPC for at least 6 to 8 weeks after the surgery. And everyone who's done that particular protocol, obviously we have some other peptides in there too, which we'll get to, but BPC is the main one in there. I mean, they're seeing healing and wound closures much, much faster than what they would regularly see. And the reason why I know is that they come back to me and they're like, oh yeah, I went to see my surgeon. He looked at the wound and went, that's odd. And they're like, what? This is healing quite nicely. So, and I tell them, yeah, that's the power of peptides. And I mean, and there's not one patient who over the last 2 years who I put on a healing protocol pre and post surgery who hasn't had that kind of reaction from their surgeon. So I still have it available. Do I wish we could get back the actual injectable? Yes, but life happens. And the beautiful thing about our industry with regards to functional medicine is that there's always a pathway we can piggyback off of to get to the end result we want. So I know the new one is pentadecanoic arginate, which is PDA. That one actually is, I like to think of it as the twin, so to speak, to BPC. And that one I've been doing some reading on it. It's pretty. It actually is the injectable version of I would say our BPC Lite, if you wanna play with that name. And that one actually does similar things in helping with collagen building, reducing inflammation. So it is one that is now obviously available for us to use. I still like the oral because a lot of patients don't like to inject themselves too much because So I tell you, you know what? In that case, let's stick with the oral because you're still getting really good benefit using the oral BPC as kind of like that foundational layer peptide of any regimen that I do.
And so, Doc Christian, have you, what's been your kind of first substitute or alternative for the BPC 157?
Yeah, so I think one of the things that I got from even the first meeting that I met you guys at, Seeds was talking and it was like, this guy, what is he talking about? I couldn't understand anything he was saying. But something that I took from there, and you guys also kind of helped me with that, is to look at this as, we are made up of cells, and the cells has the intelligence to adapt in a healthy way, in a negative way, based on the signal you give it. And it all comes to what Dr. Morris is saying, understanding pathways. Okay. So we know what is leading to pain, inflammation. How does it occur? There's all this chemokines, cytokines, proteases, all of these things that are taking place when it comes to the joint. So if you can't use BPC, what else can you use to address that pathway? So really getting that mindset of understanding pathways and what's going on. Then, if peptide is eliminated, well, I can modulate, neuroinflammation with oxytocin. I can do something with LDN. I can do something with pentosine polysulfate. I can reduce, I can work on mitochondria dysfunction. I can work on senescence. All of these processes, depending on a joint or whatever it is, all those mechanisms are taking place. So I think when those things got away, it was a shock for most of us. But the good thing is, look, like some of them are coming back. So that's a great thing. But really focusing on other ways to address the pain for people using other type of molecules, small molecules that we can explore, even GLP receptor agonists. Those are, semaglutide is anti-inflammatory. So I was using that for people that have autoimmune issues that couldn't get access to BPC, and it was doing well because it wasn't really just blocking pain signal, but addressing the whole foundational needs of the cell, including mitochondria upregulation and metabolism and all of those things that allow the cells to make better decisions. So I'm so grateful for meeting you guys and this connection because now we know how to get to it. And in a way, I hope, do you guys have a cat? There's multiple ways to skin a cat. I don't know if that's a good reference to say, right?
Yeah, I would have to say, this is Dr. Jones of the Optimization Academy podcast. We do not support skinning cats.
We do not support. I mean,
I don't support.
another good one, and I know.
So
another good one is pentosan polysulfate, and I want to pick your brain, Dr. Jones. Pentosan, I know you know pentosan, so I've used it some in my practice, and I use it on myself. Full disclosure, because I have a meniscal injury in my knee, and there's no way I'm having surgery on this. Because right now, with me doing the pentosan periodically along with my BPC regimen for myself, I'm golden. I'm good. I can still hit the gym as hard as I want. What's your thoughts on pentosan polysulfate?
So before I get into that, I'm going to tell you that this is going to sound blasphemous. Let me just start with this. Pentadecapeptide, arginate, PDA is the F bleeping truth. When I tell you that the results I'm getting clinically with PDA for injury recovery, this is blasphemy. Hope nobody hears this. Don't come at me, bro. Don't at me. I'm not here. You know what I'm saying? I'm not here to answer questions. Argue which ask your cousins. Not fighting you on this. PDA is been in what we've been seeing, and some of the results I'm getting in pain relief and that minor injury recovery is outperforming BPC.
Yeah.
Really?
because I'm having people that are within 5 to 10 injections of PDA. Like, oh, I did not expect this to work so well. And obviously,
Wow.
it hasn't worked in every single patient, but the results I've been getting with PDA have been incredible, almost shocking. I did not expect that.
So are you doing it intra-articularly or are you doing it
No,
sub-Q?
I'm not doing an IEA yet, an IEA yet, or
Okay.
intra-articular just yet, just because I haven't seen enough studies to
Yeah.
say,
Studies.
because
I
I'm
got you.
not putting something in in a sterile environment like a joint. Is like we're gonna hold off on that. But
Yeah.
doing periarticular
Yes.
sub-Q,
Yes.
I kind of had a minor groin tear, just some working because I'm old, and I was trying to do some lateral stuff that I have done since the 30s. Like, oh, I'm about to do this. I still got this. I'm on these peptides, and I went left, and my right leg was like, we don't do that anymore, and I had a little strain. Right? It's just like, you know what? We don't do that. Let me teach you a lesson here. And I was like, okay, this is not cool. And so I was like, okay, let's give this PDA a trial. And so I did a relatively high dose. I did 50 units or a milligram. And so did that next day, 50% better. Okay, great. Let's drop it down a little bit. The next day I did 25 units, 500 milligrams.
Yep.
I'm sorry, 0.5 milligrams. Sorry.
Yeah.
And that was the only two I needed, and I know that's a one-of-one case, and I've had some other cases with frozen shoulder and tendonitis, and the results have been great. So I will say that PDA has been extremely promising from a
I want
pain
to
relief
say
standpoint.
Yeah, I want to say, so one of the things that I also kind of had the same experience because it's also analgesic. Okay.
Mm-hmm.
So that's the thing. It also block pain signal. The thing with BPC is like BPC is good. It helps you to heal, but it's not like blocking the pain signal. So PDA helps with all of those things, and it's also blocking pain signal. And the good thing is when you block pain signal, now the inhibition from the brain, from muscles moving and all of that is taken out. And now your body can do what it needs to do. Because a lot of time, the healing cascade is controlled by the central nervous system. And that's because the pain signal is there. So same experience, it works really well because it also blocks pain in addition to addressing the whole regenerative and other cascade processes.
So Dr. Christian, how do you use PDA? Like, what's your modus operandi for this particular peptide?
It's sub-Q for people that have tendinopathies, just kind of how we're using BPC, knee issues, any type of strain that's not getting better, any type of tendinopathies. As we know, all those things don't have good blood supply, good supply of. It's acellular and hypovascular. It doesn't have good blood supply. It doesn't have a lot of cells there. So any type of condition that have that, it helps with it. So those are the cases that I'll be using those.
No,
Nice.
It's been great. So definitely, man, I highly recommend learning,
Yeah.
getting that involved because it's going to make such a huge difference in your practice, man,
Yes.
especially those acute pain cases. Now, kind of circling back to your question here, pentosan polysulfate has been great for our practice too, because again, it's not really a peptide. It's a disease modifying osteoarthritic drug, or DMO, if you want to call it, or structurally modifying osteoarthritic drug. Okay, great. And it's actually a heparin-like polysaccharide, right? And so that's why I got to be careful with people that are on, on these blood thinners when they're on this particular treatment. But it can be done sub-Q. But at the end of the day, so the way that we see it when I just talk to it about with my patients is like, okay, so what is this? My screen got blurry, guys. Sorry about that. So what is this doing? It is reducing inflammation in the joint. Great. That's a big part of arthritis. And we can have a whole discussion about arthritis. And one of my most frustrating things in medicine is like we don't treat inflammation with arthritis. We indirectly like, hey, you have arthritis. But it's like we call it this disease of aging and wear and tear. But if that's the case, every joint in your body would have arthritis because you're doing wear and tear. It's an inflammatory condition. I've had this battle so many times, but again, decreasing inflammation is huge in the treatment of arthritis. Number two, it increases blood flow to the joint. That's getting those healing proteins into the joint, right? And getting toxins out of the joint. So actually getting that circulation in the joint improved. Three, reduces pain, which is great. Yep. And really, the really cool thing about the pentosan is that it blocks this mechanometalloproteinase 9 or metallometalloproteinase. Yeah, metalloproteases. Yep. Long day, man, long day. So MMP9, right? And so by blocking these, metalloproteases, it actually, that's what breaks the cartilage down. So if you could actually, block that, then that's helping with that, allowing the body to heal and not letting the arthritic condition get worse. It's not that it's regenerating the cartilage, but stopping the additional breakdown of that, right? Now, the thing about Pentosan is that it's not a gentle injection. It hurts, man. Oh my goodness. Right? It stings. It burns. It bites you back. And so and then some people will bruise from it, right? They'll get bruising from it. And it's just like, okay, well, the other option is to do it intramuscular, but push it really, really slow. It still hurts, but you're also, I've seen the bruising improve by doing IM. And so we've had patients start off doing it twice a week. We titrate the dose up. And almost every single person I put on Pentosan at this point has gone from twice a week to once a week or every other week. I'm seeing that long-term improvement of joint pain, which is fascinating, right? And it's one of the few peptides, if not the only peptide, that you can actually use in an athlete that's because it's not banned.
Yeah.
So if you have an athlete, especially that's a high intensity athlete dealing with joint pain, that's something they can do as part of the regimen and actually do it safely. So that's kind of the Pentosan story, man. One of my favorites.
I actually have my Pentosan patients, and what they do is when they draw it up and I've seen that reduce the bruising, and when they draw it up, instead of pushing out all the air from the actual syringe, the needle itself, right? I have them do that, and you pull back gently, so you create almost like a very small pocket of air within the needle itself. So there's no bubble of Pentosan on the tip of the needle when they're injecting. And that has actually helped reduce a lot of bruising, because it's that initial poke, that initial break, when you have the actual, Pentosan on the actual tip of the needle, that usually leads to bruising. Once they do that, they've seen the bruising reduce significantly. And that's just in my little practice. So I say, draw it up, get to the minimum units you need, and just kind of gently pull and until you see the little bubble on the end disappear, and then go ahead.
And I was like, I think so. I've used Pentosan, and I've had I've had a few people that respond to it, meaning in terms of pain, because we know that it has all these disease modifying benefits. I haven't gone out, so I don't know specifically for people that have hip issues. I don't know what you guys have, because I've had a few patients with hip issues, and we've tried that, and it has not made a huge difference in terms of their complaint. So I don't know if it's specific for that joint. I know there's a lot of literature on the knee and other areas. But for me, it's been a little 50-50. So maybe I have to kind of dial in on the dosing. I'm doing it twice.
Yeah, it's funny. I've seen knee. I've seen wrist and hand arthritic conditions.
Yes.
I've seen that. I haven't had an arthritic hip condition, so I can't really speak on that. Have you seen anything with low back or lumbar arthritis?
I have not, but I had a patient who had pelvic floor pain, that actually did very well with it. And she did have, she also had a history of interstitial cystitis, even though this is very different from the actual oral molecule that Pentosan is based on. So she did well with it, but she was bruising, kind of the same thing. But for him, I don't know why, but I've had 4, 5, 6 patients who, it was kind of like, oh yeah, it makes sense. You're going to decrease in the breakdown of cartilage and all of these things, but still did not translate. But maybe I got to look at
the hip joint.
Maybe I got to look at
the hip joint.
Maybe I got to look at the gut. So.
No, but the hip joint itself, remember the hip joint, because of the ball and socket nature, it's going to maybe just mechanically, you're dealing with a lot more issues than the knee. The knee is a beautiful hinge. I love hinge joints, easy peasy, but for the hip, and also weight bearing too, with the way it is and how they sit and how they walk. So, I mean, it could be just the nature of just the way the hip joint is, that it's probably going to need a longer course with Pentosan, or a higher dose than what they were doing, because of the load-bearing nature of that joint and the way the joint is actually made, and the interplay with other joints as well, with their walk, with the shoes they wear, all those things.
Okay. Something to think about, and that's the great thing about medicine. We get to look at our different patients and try a lot of different protocols and figure out what's the best thing. So this is kind of like a rod, we'll kind of jump in here. What are some other top peptides that you guys are using for pain relief and for healing?
Well, TA1, obviously, that's a good one. I mean, it went away, but now it's back. So I'm kind of reintroducing a lot of my patients to it. I actually have one patient who saw migraines improve with a TA1 dosage, doing it like twice a week. A small number of units twice a week of the TA1.
Do you know
Um,
why?
uh, Tell me.
It modulates neurogenic inflammation and neuroinflammation, and that those are
Now,
underlying migraines. Yes.
is there any issue? Is there any modulation of substance P pathway in with TA1? Do we know anything about that?
So that I don't know. I don't know if it does
Okay,
anything with TA1, but the astrocyte and microglia that becomes activated are modulated by TA1. And those are the things that are creating migraine. They're creating neurogenic inflammation, they're creating neuroinflammation. Yes.
nice. Because I put this patient on it
That's
for neck issues, and I was like, just try it out, see, because it's gonna. I know there was inflammation. We had an MRI done of the cervical spine, so there's some stuff. No surgery needed. This is pain for like a couple of years. I was like, okay, let's see a little bit of DJD, disc issues, nothing much. This person's in like her mid 40s. And I was like, you know what? Let's just try the TA1 because I know it's going to help inflammation. And they came back and said, yeah, my migraines got better. I'm like, huh. I mean, in my head, it's a pain syndrome. So, and I knew there was an underlying process that I just couldn't, I didn't put two and two together. But thank you, Dr. Christian. I love that one. So I'm gonna start using that even more.
okay.
Yeah.
Gotcha.
Yeah.
So
I go ahead.
no, I was saying go ahead, man. I was waiting to let you
I
go
just got
off.
started on
No, man. That means go off, man. Go off.
God.
It's your time.
I
Do
love
you,
it.
boo boo?
I love TA1 because you talk about autoimmune, right? It's immune modulatory, so it's one of those that work on T regulatory cells, and those are involved in everywhere. So for people that have autoimmune issues, the rheumatoid arthritis, lupus, other things like that, it's great. It's good for kind of calming down the pain, and then you can introduce TB4, tyrosine beta 4. That then helps with regeneration, because one of the things that I think sometimes, and I've learned this through being in this space, is that first you need to calm down inflammation before you can start to regenerate. So TA1, TB4 on top, and a little PPS if you need it, and get people to get there. Yeah.
Good. So another peptide, now that we can talk about this freely because it's back, baby, our growth hormone releasing peptides, or G, or other,
Yes.
so we've got our growth hormone releasing hormone peptides, your CJC 1295, and your growth hormone releasing peptide, ipamorelin, and they're back. And so those have been tremendous for healing, right? So those peptides that help increase your pituitary gland's release of growth hormone and actually increase IGF-1. So have you guys brought those back into practice yet?
Yeah. So
Good.
during
So,
when they, yeah, of course, without a doubt.
you gotta
So I
ask
ended up
them.
using, yeah, I ended up using like Samorlin for a short while, but I'm now diving back into CGC Ipamorelin, that combo. And typically what I do within my practice is, it's not my go-to right away. I like to save it for a second wave. So typically what I do is, if someone comes and I can tell, yes, this is autoimmune, or this is definitely obviously inflammatory nature pain, and they haven't done anything, my goal is to quiet down the fire a little bit before I hit them with the actual GHRH GHRP combo. Excuse me. So I like to start off with, like you guys, the thymosin alpha ones, even the thymosin beta 4. I know we didn't mention it, but even that one's a good one too, along with BPC. When in the oral form, have them do that for at least 3 to 4 weeks, kind of begin to get things to calm down. Maybe use some PPS, pentasan polysulfate, and then say, okay, let's try and introduce, now that you're feeling a little bit better, let's introduce that. Because what in my head, I'm always worried, with the GHRH, is the growth hormone releasing peptides. Am I gonna wrap this patient up too fast, where the body's gonna be like, well, I wasn't done being inflamed, what are you doing? And then kind of set them back even more down the line. So I take that approach, but they're definitely part of the regimen, but more as a second wave to the attack, and to help with longevity. That's how I use those peptides when we're dealing with pain.
Yeah.
Gotcha. No, the thymosins are great, just because, again, and I know it's like some of the things it's a recurring theme, is that pain and inflammation are these strange bedfellows, and not really strange bedfellows, they are bedfellows, right? So the more inflamed you are, the more dysregulated your inflammatory pathways are, the harder it is to get out of pain, the harder it is to heal, the harder it is to regenerate, right? And so anything that can help modulate or balance or calm the immune system down when it needs to, it's going to be amazing for that. And that's where the TA1, the thymosin alpha 1 peptide comes in. And then again, even I've got some patients who have some autoimmune arthritic conditions, or I'm sorry, autoimmune inflammatory conditions. Amazing for that. Amazing for that. I mean, so again, it's definitely multifactorial when it comes to treating rheumatoid arthritis, but we've had amazing results with TA1 and RA, like incredible, just getting that person out of pain so they can function and be out of pain and live their life more healthy and comfortably. So, right, I think you guys are right on the money with that as well. Now, one of the peptides that you guys mentioned really briefly, and I was like, wait, we got to come back to that, is the use of GLP-1s for pain relief.
Yeah.
And so, and that has been, it's almost like we didn't expect that. It's like, all right, well, hey, we got this great weight loss peptide, it's going to reduce your appetite. And then your people are coming in like, wow, I'm feeling less pain. And then we realize there's an anti-inflammatory component to it. But then there's also that state where it's like, okay, all right, I'm in pain, but how long do I need to be on this, right? It's like, do I need to be on this forever, right? And I think that's where some of the strategy with dosing come in. What are you guys seeing with reducing pain and seeing inflammation decrease with GLP-1 agonists?
I will go first because I love GLP-1s, okay? I'm a pain doctor. None of the medicines I have has any benefit for anybody, okay? I got gabapentinoids, opioids, NSAIDs, and, more antidepressants and junk. So I love GLP-1s because, one, the very point you talk about for pain, because I knew about the anti-inflammatory benefit and all of those things. So I have some patients who have rheumatoid disease and they couldn't be on biologics. We lost the weight. They're doing well. Pain got better. Couple more patients, pain got better. And then when you take them off, now they have pain. But the thing I also recognize, and I don't know if there's any literature on this, even at a very lower dose, 25 units weekly or bi-weekly, is actually how I'm using for some patients who don't want to be on biologic. And it's just great. It's well tolerated. They don't have any of the other side effects that we have from of the medicine. So I definitely love GLP-1s. And then I also want to go back to CJC epimoreline. I also I like it even in acute pain. When somebody's a little bit older people, older gentlemen, they have an acute injury. One of the things I like about it is this delta sleep that gives people sleep so well, because when they sleep, then they're making all these antioxidants, all of these things that they're going to need, hormones to heal things faster. So I also tend to kind of bring that in a little bit early, even for people that are older, and that seems to kind of help them speed up. But GLP-1s, one of my favorite peptides, and I think people just have to learn how to use it. I talked to a patient today. There's always all this nonsense and junk, misinformation. We're doctors. Everything we give to patients have risk and benefit. Conventional medicine, how they do pills is we give it to people, and we don't talk to them about how to mitigate side effects, how to use it effectively, how to change your habits, because that alone is not going to take you far. So that's all I got to say about GLP-1s, but that's my favorite right there. My favorite peptide, if I got to pick one.
So my GLP-1 patients are usually more of because I do a lot of weight loss, a lot more of the heavier variety in terms of the more BMIs above 28, 29, 30, 31, going up there. And those ones, they have seen the reduction in pain, but primarily because of the amount of weight. And I know, because they'll even tell me, yeah, you know what, ever since, I dropped all this weight, my knees feel better. So in their minds, which I think is a good thing, in their minds, okay, when my weight is less, I hurt less, which is true. There's the pounds per square inch is less, but the inherent, most of them don't really care about the fact that there's an inherent anti-inflammatory effect of this class. But I definitely hammer home, okay, good. So you're feeling better. Good. You've lost 15, 20, 30 pounds. What's the next step? Well, I want to gain back because my back feels great. My knees feel great. My hip feels much better. I'm like, good. So then we switch them off to kind of like you, Dr. Christian, like every 2 weeks more of a maintenance type situation. And just to kind of see how things go. And if they notice the weight begin to creep back up, or the pain getting a little bit worse, or they're just like, okay, I felt better when I was on it. Because sometimes they can't tell you, they can't pinpoint why. So they say, I just felt better when I was on it weekly. I'm like, okay, cool. Well, let's go back to weekly and let's see how you do. So it's and that's the beauty of it. You can adjust based on individual experience of each patient.
Yep.
Yeah, and there's many ways to get some of those benefits of it when it comes to inflammation and
Oh yeah.
actually like longevity with the GLP-1s by
Yeah.
using a lower dose, right? So kind of like that low, low dosing it, quarter of the starting dose, half of that, depending on the patient. Sometimes we have people doing it every 2 weeks. It's really small. And we're seeing a lot of those pain benefits because some people are like, hey, I'm happy with my
Mhm.
weight. I'm not trying to suppress my appetite, but there are other benefits that can be
Yep.
utilized with that. So
Yeah.
that's where we get to utilize that power of it, man. So there's so many things that we could be covering, man. And we go on, and I really want to appreciate you guys making time for this. And I feel like I want to bring you guys back because, man, I had a very ambitious agenda. I was like, oh, we're going to talk about ARM and PRP and regenerative injections. And I'm
Well, we
like,
can take that on the next time for
yeah,
sure. We can
I
definitely take that on
know.
next time. I'm
I
down.
know.
I'm down.
I know. I know. Like, oh, like red light therapy and
Oh my gosh,
ultra
yes.
shockwave therapy and
Shockwave in my practice
microcurrents.
all day long. That's what we do.
Oh man, but we'll make another part 2 to this, man. It's just like
Oh yeah.
it's like you get going, you're like, man, there's so much, right? And there's so much more we
Yeah.
could cover. And even in these conversations we've had today, I'm just glad to have this conversation, get it started, and have people think a
Yeah.
little bit different about pain and pain relief. And it's not so much, hey, take this pill, take this steroid injection, and hope that you get better, but giving your
Yeah.
body the things it needs to get better. The body has this innate, we want to heal. We're designed for healing, but
Yeah.
sometimes there are roadblocks to healing. And our jobs as clinicians and doctors who practice functional medicine and cellular medicine and naturopathic medicine or integrative medicine, whichever path you're on, is to find out what that obstacle to cure, obstacle to healing is and remove it for helping our patients remove it. And then there's coaching, like you said, it's that, hey, if you're in pain, sugar is not your friend, dairy is not your friend, gluten's not your friend, and processed foods aren't. But changing that relationship to these different things to help yourself out, and that's our jobs, man. And that's why I'm really honored, to be part of this community and that you guys were able to make time for the show. Before I let you guys get out of here and get your weekend started, Dr. Morris, where can we find you and learn more about you and your practice?
So definitely hit me up on Instagram. It's at drg.amgforlife, AMG for life. We're in Tucson, AMG Medical. We have 2 offices. The other one is AMG Center for Regenerative Medicine and Aesthetics. I'll give Dr. Greg in the show notes, our website and all that good stuff, so you can check us out. I mean, it's been an awesome journey. I thank you so much, Dr. Jones, for having me on this. I'd love to do more. I mean, it's all about education, getting patients, involved in improving their health overall. And my parting thing is, and please feel free to use it. Patients have to realize they're going to pay for their healthcare in one of 2 ways: by choice or by force. So you be the one to decide how you want to pay for your healthcare. And by choice, it's an investment. By force, it's like paying taxes. No choice.
Mm-hmm. Definitely. Thank you. Thank you. Appreciate that. Dr. Christian, man, where can we find you and find more about you and your practice?
Yeah, so my practice is in Wayne, Pennsylvania. It's a suburb of Philadelphia. And the name of my practice is Ether Medicine. So people can check us out on our website. There's a lot of information there. Ether is spelled AETHER medicine.com. And what I will also say is this is really wonderful to be able to even have this discussion with you and understand it, because 3 years ago, I didn't understand any of this language, mitochondria, all of these things that we learn in med school, and really going back to how we use that to solve health. So really, this has been a great honor, and I've learned so much, and I look forward to the next one, because I think there's a lot more that we can educate persons to become aware of, because it's not just blocking pain signals. And I've been in this pain space for so long. We keep making medications, and they're all coming out with medications, and every one of them is, how do we block sodium channels? How do we block, instead of, okay, let's address hormones. Hormones are anti-inflammatory. It's going to solve itself. Let's work on sleep. Let's work on stress. Let's work on trauma. All of these things that influence or perpetuate pain, because people understand what starts the pain. They don't know what keeps them in pain. So this has been great, and I look forward to doing more of this. Yes.
All right, guys. And I will have in the show notes information about Dr. Christian and Dr. Morris and where to find them. So don't worry about trying to memorize that and running to Instagram. It will be in the show notes. So, guys, I want to thank you for your time. And you guys that are at home listening or on your Spotify and iTunes or watching on YouTube, I want to thank you all for tuning into the show. And I will see you next time.